All right, and with us we have Kyle Gilbert. Kyle, can you tell us a little about your background and where you come from?
Yes, my name is Kyle Gilbert. I'm currently with Konfidi Healthcare IT Consulting. Uh, been in the industry really my whole adult career. I started as a technologist, moved over to tax administrator, and then some leadership roles throughout the years, and kind of brought me into where I am currently.
Well, I think that's where I first met you as in your PAX administrator role. So it's great to be talking to you again.
Yes, you too.
Hey, gentlemen, if you don't mind, I'd like to interrupt you real quickly and take this moment to introduce Dan Crump.
Hey guys, very nice to meet you. Dan Crop here. Cover healthcare accounts in Houston, San Antonio, and Austin for Pure Storage. It is my pleasure. Thanks for letting me be part of the inner circle here. This is cool. Thank
Oh,
you.
yeah. Very welcome, very welcome. So Dan, you're going to get a crash course along with my colleagues here, but I'll let the we'll get. I want to make sure we can continue for on time here. I know that Kyle, you just took the time to introduce yourself. Thank you. I know Brandon, you just joined the call. How are you?
Good. Good morning. It's starting late. Already have meetings this morning.
Uh, Brandon, you don't mind? Is it just me, or was that a little bit of an echoey?
Yeah, that sounded like mush mouth from Fat Albert.
Oh, no. Hold on,
Rubber,
wait.
rubber. No offense, Brandon. I know we just met.
Yeah,
So,
let me fix my audio. I'm
Oh, there.
switching between two different computers is what's going on.
I totally understand. I think we all live that world. I know I've got two laptops, four monitors, a couple different headsets. So it's which one am I on right now?
Amen.
That's what this whole working from home, the home office is like.
But Dan, just a quick thing here. Kyle Henson is the owner of Imaging Heartbeat, and also he is I don't know if he's a consultant, Kyle, but you also are working for Change Healthcare on their PAX initiative.
I am. I'm a contractor on the initiative to move a national health system, move their entire archive onto the cloud, or their entire image archive onto the cloud, which is different, I guess,
Wow.
than just saying
That's so
data.
cool.
Yeah, it's good stuff. Really excited to be learning. I'm learning a lot about the cloud, and that's where I want to be, right in the middle of things.
Kyle, your
Yeah.
name is so familiar. Do you publish a lot of articles?
I've written a few on LinkedIn, so I do. I'm active on LinkedIn and social media, just sharing. I read things that I find interesting, and I like to share them with everyone else. But I'd rather. I'm here actually. I would really like to learn from Kyle Gilbert and Brandon about what they're seeing in the industry and what's going on in their world.
I'm gonna let Kyle start because I still can't figure out my headset.
Yeah, so I'll kind of start off and kind of give you a summary of the last probably 18 to 24 months of what I've been really working on in the industry, I guess you could say.
And
Um,
Kyle, forgive me for Kyle,
Sure.
I'm so sorry to interrupt you, but you're with Confidi Health, correct? Is that sound
Correct.
okay? And where you guys headquartered out of?
Out of California,
Okay, okay, thank you.
and we cover coast to coast nationwide. Um, Work with quite a few different people, different organizations, uh, and I'll kind of circle back to that and let Brandon really get into those details as far as what Confidi is and what we're all about. But but just in the industry, what we've been seeing is uh, almost a jump to the next generation of imaging, and not so much of a what I've heard in the buzzword years ago was a deconstructed PACS, but
Hmm.
more of a true enterprise imaging solution, and that can include pathology, EKG, light source imaging, you name it, all in one solution. And that's really what gets me excited. Taking a deep dive with the vendors in the industry today, and what they're putting out there, because it's not only that deconstructed PACS, kind of pulling out that middle layer, but it's so much more when physicians and clinicians can sit down at one station, and utilize one instance of a viewer to to view cardiology, radiology, CT, cath lab, all in one with a pathology slide pulled up. I've sat down with multiple physicians, and heard their feedback from having that functionality, and they love it. I was actually very surprised. I spoke with one radiologist in the Ohio area last year, and he utilized the pathology slides way more than I thought a radiologist would in the pathology report. So it's interesting to get out there and talk with the clinicians and the radiologists. And it's kind of eye-opening.
No, that's great feedback. That's really good to hear. So it sounds like if they do have access to the proper tools, right, and to the images, even the pathology, that they're going to use them.
Yeah, correct. And that's where there's I think a shift that will be going on in the industry in the next, I'd say, 1 to 3 years, as organizations start to realize that PACS is no longer what it used to be. When all of us think of what PACS was, and usually you have a radiology viewer, diagnostic imaging viewer, then you might have an echo PACS and a cardiology or CVIS PACS. They're so siloed and so disparate that it's hard for a physician to sit down and see all the images. Some reading rooms you walk into and there's 5 different PCs in there.
The old war room.
Yeah.
So who's actually leading that challenge, that change? We hear about enterprise imaging, but who is it that you're seeing within health organizations that's actually saying and driving that change to integrate the other imaging sources?
I will say, in my experience, it's usually a small group of forward-thinking individuals, and that can vary widely from who that is. I've been on calls where sometimes it's CIOs, and I've been on calls where other times it's PACS admins that are driving that change, because they're out there getting that literature, or doing the webinars and seeing what's actually on the horizon. So it's a wide array of individuals, I would say.
And what's...
Can you guys hear me this time?
Oh, you're much better.
Clear finally? Excellent.
Very tall.
You said very tall. So, my perspective on it, obviously very similar to Kyle's in terms of experiences, but he's right. It seems like it's a select group of individuals that kind of drive this from understanding a technological perspective. But the real driver is what happens is when you get down to the financials, when you get down to the real ROI and the consolidation of imaging systems. That's when you get the attention of your CIOs and above. And the thing is that I think a lot of people don't realize within organizations today, it's not necessarily the CIO that's driving this. I think it's up to the CFO. And that's the oddity, because the CFO is not educated on imaging. And so you're starting from scratch. And getting through that education portion is the hardest part. Is, okay, now we understand what's going on. Now we understand what we can possibly do, and we can save money. Okay. And am I going to keep my physicians happy? Is this a tried and true solution, or are we doing a moonshot here and we're going to be set up for failure? That's the biggest questions that come out of it. So, and keep in mind, this really, enterprise imaging, it's not really something new. We've taken a shot at this before. I mean, I think 7 years ago plus, I'm trying to think of the first time I heard about it. We started with VNAs, and then we started talking about the deconstructed packs, and that was the term back then. It was deconstructed packs, and we were thinking about it from a radiology perspective, which radiology is always first, but there's much more going on. And then now, we circle back and they said, no, actually, we want to go back to the traditional classic model of packs. And you saw vendors kind of do that shuffle. And now you're seeing it come back around because the technology's gotten better. You don't have as many limited choices. And so they're seeing the advantages now again. At least that's my historical perspective on how I've seen this going, where it's kind of ebbed and flowed, and it's done this boomerang effect back to what we were doing before. And now we're talking about digital path again, and maybe this time it's real. So that's the way I look at it.
So, I mean, you said something that I think is critical, and that is coming up with the ROI. And, because if you, without it, I mean, the reality is we have to find a budget to pay for it. So what are you seeing as the ways that you're able to find that ROI? And you said lower costs. Where do you see those costs coming, those lowered costs coming from?
Well, number one is consolidation of infrastructure. In terms of if you're leveraging the same infrastructure for doing multiple things versus having a single vendor solution for your clinical reference viewer, a single vendor solution for your radiology packs, a different vendor for your VNA, even possibly a different vendor for your work list or workflow orchestrator. Now you're looking at an integrated SLA that becomes very complicated and very likely to have a lot of finger pointing, and the cost goes up. So you're looking at support issues, you're looking at cost, you're looking at infrastructure, all of that kind of plays in. And then you're thinking about user experience in terms of, can you upgrade a system that's that dynamic on a regular basis? Do you have the IT staff with the chops to handle it? And are you going to actually be doing a regular upgrade cycle, or are you going to upgrade maybe once a year, which would be horrible? So, I mean, that's just off the top of my head, but there's other factors that come in as well.
So, Brian, I got a question for you. Are you finding that the stakeholders today, particularly the CFO, are they still looking at traditional CapEx models? Are they actually now entertaining the idea of, let's say, a subscription-based model? One that's more focused towards operation.
I think it's both. I think I can tell you recently that I put together a proposal, and Kyle worked on this as well, is we were looking at, we had a traditional model of what was quote unquote enterprise imaging, but it wasn't favorable in terms of the contracting. So we're looking at what would pricing be if we looked at this as a true enterprise imaging perspective. And the thing is that up front, there's quite a bit of CapEx, which a lot of organizations don't have right now. But then the big question is, and this is sometimes overlooked, is let's look at the OpEx, and is there a huge cost savings there? Can we span this over a period of time and still realize an ROI? And if the answer is yes, then you get people excited and they start looking at it as, okay, we probably need to do this.
Okay, thank you. Interesting.
So where are the biggest challenges in making that shift from, I guess we'll say traditional imaging to enterprise imaging? What are the key considerations or the things that you see that are getting people tripped up?
Other than money?
Well, that's of course, right? Always we have to talk about the money, but yeah, assuming that it's been funded because they had a great CapEx OpEx model. What are the next things they have to really look out for?
I think the main problem is having a true strategy from the get-go. Is being able to know what you're going to do and how to do it. So a lot of organizations, they either lack the internal subject matter expertise, or because you don't have key individuals on board and educated, you have stumbling blocks. until you get past that and everybody has at least a baseline understanding of the advantages, what you're doing with the technology and the cost associated, and what the long-term roadmap is, you're going to have some struggles, because a lot of people love to look at it within their own, I guess I would say, fiefdom.
Mm-hmm.
Of, well, I'm cardiology. Oh, okay, but I need you to expand your horizons for a moment and look at this from a holistic perspective of how can we be advantageous to all the ologies, all the specialties, and do something that really helps us all out as a whole.
Yeah.
That's the tough part.
So with that saying that made me think of telemedicine for a minute, right? So if you're starting to expand into all the ologies and having the ability to have visibility into all of that as a segment, are you seeing that are your clients talking more about a telehealth strategy, or is that something that they're implementing? Is it having any impact on these decisions?
Absolutely. I mean, telehealth's always at play. I mean, radiology is usually the main driver. And telehealth, I mean, you're talking about teleradiology first, but then telehealth beyond that, especially with COVID, I saw a lot of that come up looking at what is, telehealth and home health is the best way that I could describe it, in terms of, okay, maybe we don't bring the patients to us, maybe we go to the patients. And so there's a large portion of the telehealth, but also looking at mobile technologies and how can we incorporate that with our systems and be able to leverage, differing bandwidths and still connecting in and keeping our system whole, and images moving around from one place to another with a multitude of different devices, providers, readers, you name it. So sorry, I kind of threw spaghetti at the wall at your question, but that's some of
No, it's forgive me. I know it's good. I like to see. I think that is a conversation that's taking place in a lot of institutions. I'm not personally involved in a lot of those meetings, but you would be thinking that based on how things have changed, right? How needing to touch people at home and needing to access their records or different imaging, right, or getting access to their labs and having that as a consolidation, as you mentioned earlier, I think that would absolutely impact not just the outcome, but also satisfaction. So I was just curious if you're hearing more, or just more requests about, hey, we have a telehealth strategy. We'd like to find out how, you can help us make these decisions or educate us further on how we can leverage our enterprise imaging strategy, right? And then talk about, oh, by the way, because it is telehealth, how can you help us keep it secure? And Mr. Hinton, I'm sure you probably are having several of those conversations internally. I wouldn't be surprised.
I think that one of the more interesting developments I've seen from, as you pointed out, home health in terms of the imaging side is there now is, point of care ultrasound has been on the rise everywhere, but now I've seen some new products come out where they're actually trying to create patient generated medical images, particularly in the ultrasound realm. I don't know. I mean, talk about that's really bleeding edge, but it's there's a lot of point of care ultrasounds that are now mobile based. So that one really that's pretty shocking. But I've been reading some good studies about that.
So is the tech going to the patient's home and actually, doing that ultrasound, or is that what you mean?
No, it's actually you send the transducer to the patient. The patient acquires their own images, being guided by an app that tells them exactly how, which is also connected to the sonographer. The sonographer is telling them, no, move it this way, move it that way, and they're actually.
Oh goodness!
I don't know.
Wow.
I've not seen her
So
work
easy
with
a
this.
patient can do it.
That's right.
Are you talking about Butterfly?
I didn't. That's what I didn't name any brands, but I did read about that, and yeah, I've heard some. I mean, there's some conversations around it, and is that the way we're going? I don't know. I've heard.
Well, think of the simplification. I mean, it makes sense. I mean, you have an iPhone or device, and you have a transducer, and you're up and running. Is it ever going to replace a trained sonographer? No, but in terms of point of care, I think it could be effective. Yeah.
Right. point of care ultrasound is one that I've really, looked at over the years. Is like, you know, the business case for it. There's images being generated everywhere, and I think that's, one of the things that
Yeah.
I've seen been a big driver to get into enterprise imaging, because that's the most familiar to folks like me who are generally radiology, but it also gets us outside of the department. So, is that something you're seeing a lot of?
I'll jump in there and
Sure.
I'll say I have not seen a whole lot of that currently, and but I do think there are some pointed use cases,
Hmm.
and kind of to Brandon's comment of will that replace a certified sonographer? Probably never, but follow-ups I actually see a beneficial use case such as like abscess drains, cyst drains, something
Right.
that's rather basic, and instead
Hmm.
of having to drive into a facility, especially in rural areas, maybe you could just scan your leg and see if that cyst is still there or that abscess truly was drained.
Right.
Week two or two follow up. I see some. I see that as being beneficial. I've worked with enough radiologists and enough sonographers that they have a hard enough time at times getting the images that the radiologist wants. So I would see a patient having a very hard time, acquiring diagnostic quality images.
So, what do you see in terms of point of care ultrasound elsewhere in the facility? So, if we take that back one step and say, well, what about point of care ultrasound in the hospital, like the ED, or even a physician office, but not patient generated, but physician generated point of care? What are your thoughts on that? And is that really affecting the enterprise imaging strategy?
It is.
It very much is. Actually, through every organization that I've spoken with in the last 5+ years, it is a hot topic of what do we do with point of care ultrasound and what do we do with the images and the workflow associated, because nobody has the answer in full. There's a lot of theory, but I have not yet seen a fully implemented workflow that really matches the quality that diagnostic imaging has set over the last 10 to 15 years. I think it's um, I think it's on its way to being there because the conversations that I've had with multiple vendors in multiple organizations, but I think it's still a work in progress.
So, guys, I got a quick question about point of care, if you don't mind educating me a little bit further on this. So, when you see point of care, you're referring to patients walking in, let's say to an ER. Are these patients that are having a crisis? Is that why? Because it's not being. I mean, I'm not confused. I know what point of care is, but in what setting you're referring to? Because you're talking about the differences of diagnostics.
It's typically there's a multitude of scenarios. So if we're talking about emergency medicine, I mean, this could be as simple as, I mean, they're looking for traumatic injury. They might be looking for a vessel to ensure there's a blockage. There is, to the extent of clinics that will use point of care ultrasound as well, just for initial assessment by the physician. Typically, these are not meant to replace diagnostic studies. These are meant as a quick look. Maybe I need to find a vein, use it for that. There's a multitude of applications in which it's useful to the clinician at that time. But what happens is if there are findings, if there are significant findings, typically that leads to a full diagnostic exam. Like, okay, we found something, now we know what to treat, and let's move them over to ultrasound if available. And that's the other thing. What time of day is this happening? This is in the late hours of the night, your sonographer is on call and not in-house. Yeah, your ED physician's probably it, or doing sonography to make sure that they can make diagnosis quickly. So the problem of why point of care ultrasound has really come to the forefront, it's always been around. Just problem is it's not super prevalent in terms of us storing the images or talking about it, because there's reimbursement for it that a lot of organizations are leaving on the table. they don't collect it because they weren't meeting the requirements of storing the images and making sure that it was meaningful. So then it comes into play of the workflow. Okay, yeah, we want to store it, but we need to store it with metadata. We need to have some sort of workflow. We have to have a billing process. And we don't want to make this manual and clunky because ED physicians, especially who work with us constantly, they don't have the time for that. So this ends up being a workflow of, okay, it needs to be a point of care or encounter based workflow. So you're either taking the ABT messages from HL7 of, say, a packet being drawn for a trauma patient, or you're taking the SIUs from a scheduling event, and you're having those converted into potentially a DICOM DALI work list into that point of care ultrasound device. The other thing is that we have a ton of ultrasound devices out there for point of care that aren't even DICOM capable. So then you have that item you need to think about depending on the age of the equipment, because all of our hospitals out there across the United States, we have some old stuff. Now Kyle brought up, I mean, we have also some really advanced stuff that's super simple. You have an app and you can be up and running with probe attached, but not everybody has that, and not everybody has the budget to go and switch over. So there's a multitude of factors there. You have the work list, they select off of that. You also have the expensive applications built into the EHRs that you can use. The question is, what's the ROI comes into it again, as always. Okay, how much is this going to cost us, and how much are we going to realize in revenue? But then it's also a question of clinical functionality. Is this going to be efficient for my providers, or am I going to cause them more trouble and wait for them to be able to, administer care to a patient? So the problem is some people trying to follow the workflows like from radiology perspective, where they put in an order, they have to wait for the order, they scan the patient's barcode, they go through all these processes, and then they can finally scan the patient, in which at that point the ER physician's frustrated. And I had this call yesterday, so that's why it's fresh in my mind, of talking with ER physicians that are going, yeah, I don't want to do this anymore, and don't understand why you guys are leaving money on the table. So those are the main drivers, and that's how this has come up. And then you can leverage your DNA, you can leverage a few other things, but probably the best route, keep it simple for retention, and make sure that you have a viewer that's ability to pull it back up for them to do their QA review. That's it. Like it's easy, but there's
Is that all?
Oh, really helpful.
No, it's like you said, it's a hot topic. I hear about it all the time, but I don't know that we've really come to some best practices yet.
So the thing is best practice. Yeah, there's a few ways to do it, and it depends on what avenue you want to take. You want to leverage your existing systems, or are you going to do it through your EHR? Do you have an EHR that is an order-based encounter setup in terms of its configuration? Because then that gets problematic. If you have an EHR that's relying on an order event versus you being able to send a report in or an ORU in directly, that's a different discussion as well. And I know, like Kyle's smirk on his face, he knows what I'm talking about, because it becomes problematic with certain vendors. And so you got to figure out, okay, are you having a third party acting as a risk for a period of time to create an ORM? And is the system going to accept it? Is it set up for that? And all the complications associated, excuse me.
Yeah, there's certainly a lot of challenges to it. I don't know, on a quick time check, is everyone okay? We're a little past the hour here.
I'm okay for about 15 minutes.
So, okay.
I'm okay. All good.
All right, Wayne.
Yes, sir.
So, you mentioned that everybody does it differently. So, picture a world where with no constraints, what would be the perfect workflow? If everything was working right, what should we be striving to? Does
Are you talking about just point of care ultrasound, or is that a broad?
curiously open-ended? A clean whiteboard. How would you how would you advise someone that just without constraints? How do you think it should work?
I mean, speaking about it generically,
Or I mean, let's take the ultrasound.
the most fluid possible workflow you can have. You have to start with the clinicians. I mean, removing all of the pre-work. I mean, something that's so fluid that when they have an encounter with a patient, everything's at their fingertips, that they're not sitting there staring at a screen typing into it while they're working with the patient. They're not fumbling to pull up a study in context for the patient. It's not limited to that encounter in terms of the imaging information, that they have a timeline view at their fingertips. They have all the tools that I'm thinking of this from a perspective of a regular provider that most patients come in contact with. So most patients don't come in contact with radiologists, or, I mean, maybe they'll talk with their cardiologist. I'm really looking at this as a broad stroke. Getting to the simplification of back to the human element of having that direct, physician-patient contact, and not being interrupted by the technology and all of the documentation required with modern healthcare. That's what I see. That's the holy grail, right? And that they are able to move fluidly as they choose without restrictions. Now, is that going to happen anytime soon? Probably not. And what does that look like from a system perspective? You're going to have a pretty configurable and adaptable system, and then you're wondering right now, the technology we have today, that sounds like a real complex environment, and you're going to need a very adept team to be able to manage that. So I gave you a generic answer back. I'm sorry.
Well, luckily, I know someone who might be able to help augment with some very adept teams and help organizations build that structure.
This is true.
So, I think one of the things that I hate to bring it up, but how has the practice changed since February or March? And how can organizations succeed in the world in which we live in today?
Go ahead, Kyle. Yeah, let's have you take a crack at it.
I will say that I know there's been a lot more requests for at-home reading stations, at-home workflows, and I know that's always been the case for really years. But there's at times organizations push back for one reason or another. But I think since the outbreak of COVID, it's been a wake-up call that there needs to be telemedicine needs to be more fluid, more fluent for the at-home workflows, because the workstations are not ISP bandwidth may be usually much lower, especially in rural areas than you have at your main facilities. So how do we make that work for all of the physicians? And I think that's been one of the biggest questions that a solution needs to be put in place for those places where you can only get a 1 megabit per second connection at home. What do you do there? So I don't know if there's a great answer, but
yeah. I mean, deployment is really what it comes down to. In terms of, I heard as we moved into COVID, at first, the radiologist thought, well, I'm kind of contained in my little closet of a reading room, and maybe I won't be affected. But then they quickly realized it's farther reaching than that, and it became problematic where radiologists, whether for risk of their own health or because from a business opportunity, it makes a whole heck of a lot more sense for them to be remote and in their own environment. They started pushing and saying, look, I don't want to be tethered to sitting in front of this thick client workstation in the reading room and possibly exposed, and then in turn exposing all the other people I come in contact. And it's a reasonable request, especially in today's day and age. And the struggle immediately was, okay, how do we quickly deploy solutions for these radiologists that weren't already set up to do this? And we have a standardized build for our workstations? Do we have diagnostic quality monitors that we can deploy out? Because those are expensive. Are the radiologists willing to put up some money for this? Can we put them on a workstation that works for multiple organizations? Because ultimately that's what they're looking for. Is security going to have a cow about it? Probably. Depends on how you do it. So then working through that and thinking about these things where we've all touched on them before, because it's not like remote reading's anything new. It's more of, okay, we need to fine tune the standards around it and get to a faster deployment methodology of, okay, we have stuff on the shelf where we can grab, we can image, we can deploy out, and we know what it's going to cost if it's BYOB for the radiologists. And then you're thinking about, let's make sure we're not compromising security, and then you have start block considerations. You want to make sure you're not giving away favors or vice versa or anything along those lines. So you have to have those considerations. And then, even still, regardless of remote reads, you're still going to have procedures and need a radiologist on site. So then you get into the complicated act of, okay, who's drawing the short straw? Or is it going to be shared? And how are you going to ensure to keep them safe the same as everyone else within your facility? So all those things came into play, and we had to deal with that for a multitude of organizations. Some react better in those scenarios than others. Budget is always a factor. I mean, if you have the money to do these things, it sounds like, yeah, you make a plan and you execute. If you don't have the money and you don't have the mechanisms to get the money, struggle. And that's the sad truth. And it makes it sound like I'm talking about money a lot, but it's a huge factor.
Right.
If you have it, you're doing well. And if you're an organization that's struggling, you have to go on, you got to get creative, even more creative, whereas otherwise the plan's pretty simple.
Oh, I appreciate you bringing that up. I'm curious, guys. Has anyone had any more conversations about revenue share models when you come across a group that you know is highly capable, but also financially struggling for whatever reason? We talk about being creative, right? Is that a topic that's just gone now and is no longer even talked about, or are there organizations out there that you think would actually say, hey, you know what? That's not really a bad idea.
It's prevalent right now. I can tell you right now, we're talking through a deal where an organization that previously had never thought about it is, we're going through the motions of thinking about how to form a profit center in terms of a SaaS model for imaging. And it's kind of well, why didn't we think about this before? I mean, yeah, it makes sense. We have it. And we're leveraging, because, if it's a larger enterprise, they're leveraging a lower cost of ownership that they could pass on the savings to a smaller organization that otherwise is looking at a huge capital outlay to put a new system in. Why don't we simplify this process, provide a pass on of those savings while making a small profit and make everybody happy? It's kind of a no-brainer, but the problem is going through all of the bureaucracy and putting together the documentation agreements of how you do that, because it's not usually done. But ultimately, technologically, it's not difficult today. It's more of the operational and business aspect that needs to be looked at.
Thank you.
Yeah, but the accounting on the back end of that, especially when you factor in the accountability with Medicare and Medicaid and all that, and tracking that is definitely challenging.
Agreed. And that's the reason why I think a lot of those deals die. Is nobody wants to deal with that.
Nobody, when Joint Commission shows up, it's like, well, they did it.
Who owns this one? Who's responsible for retention? Who's responsible for
I mean, that's really interesting. What do you see in the prevalence, or what percentage of deals are people interested in getting into those more interesting discussions? Is that common? 50%, one third, three quarters? What do you see?
I think it's always a thought-provoking idea in which you get interest right off the bat, and then to be honest with you, it seems like 8 out of 10 times it kind of fizzles out. They start to realize the constraints that we have, and then it kind of dies off. I think it takes somebody being really aggressive about wanting to put it forward. I mean, really, it's once you do your first deal, you set the basis, and then from there it just flows. It's always doing the first one, the hardest part.
Gotcha. Wayne, did you have any other questions?
No, I just, with this much intellectual property, sitting in these meetings, you guys are touching a lot of clients who are, cutting edge. And I really enjoy hearing about how you guys are making that impact out there in the healthcare market and where you see the market going, especially with all the changes. So I appreciate you tolerating, my interruptions, but sometimes you guys say some things that really they're important. And for a guy like me, it's just good to be able to put my finger on that pulse and measure it.
So, just as we're kind of wrapping up, for those that want to know a little bit more about Konfidi, can you just tell us a little bit about what Konfidi is, your specialties, and how people might be able to get a hold of you?
Sure. Yeah, and I'm sorry I'm doing this backwards because of my mic issues. So Konfid Healthcare IT Consulting is full service healthcare consulting firm. Obviously, our specialty is within imaging, and specifically imaging, enterprise imaging. Focuses between providing whether it be strategic advisory, discovery assessments, vendor selection, even optimization of current environments, and implementation are our core services. We also provide some level of staff augmentation, but we like to look at it as value-added staff augmentation, because we don't just provide a body, we also provide tied-end staff augmentation, a level of consulting services as well, because we want to make sure that you're getting everything for your dollar. But we're a small firm, slowly growing. Right now have about 7 individuals that I would deem as really some of the best and brightest that we have out there in the industry today. And we really have a passion for imaging to try to make solutions better for the provider and better for the patient. That's our focus.
Well, I know.
Brandon, is your practice built around any specific systems like GE or Sectra or anything of that nature? I mean, or is it more general?
No, we're taking a very agnostic approach. We don't look at it as one size fits all. I mean, every environment is unique. Going out and doing a rip and replace is actually fairly rare, at least what I've seen. In that you want to leverage at least some of the existing infrastructure that you have to, again, bring up that ROI, reduce that cost. I think sometimes there's solutions that aren't appropriate for certain organizations, or they need additional added capabilities and functionality. That's kind of the focus, is what can we do with as little as possible to make it right. Now, sometimes you have organizations that have the budget and they want to go moonshot. Let's tackle it all. Let's make this right from the ground up, and that can be the right approach. But that's not always the case. So, I mean, that would be my answer to your question.
Well, and I've worked with you guys before, so I agree with your assessment about having some of the best and the brightest. Do you have a website or a phone number that people can get in contact with you if they need to?
We do. We are at konfidihealth.com, KONFIDI health.com, and phone number and contact information is on the website.
All right, I'll make sure we put a link there underneath the video once we post it.
Appreciate that.
Well, guys, it was really good to meet you. I'm glad you could join us this session. Kyle, thank you for championing this. Dan, good to have you. Kyle Gilbert, always good to connect. Brandon, very nice to meet you. It sounds like you have a thriving practice. Look forward to learning more about it.
Well, thank you, gentlemen. Appreciate the invite. This is great.
Thanks.
Thank you.
Everyone have a wonderful day.
Take care. Take care.
All righty.
You too.